Okay, we're back to talk about prostatitis, and we're in Chapter 13, Men's Health, on page 656, and let's get started with it. There are several types of prostatitis. You can have acute bacterial, chronic bacterial, non-bacterial prostatitis, which is most common, and then prostodynia, as well as an asymptomatic inflammatory prostatitis, and we'll talk about these a little bit more. This condition happens typically in sexually active gentlemen between the ages of 30 and 50. With chronic prostatitis, it's more common in the older gentlemen greater than 50, and athletes who run long distances or participate in vigorous exercise activities can be predisposed for prostatitis. So based on those causes, you can see where some of your risk factors are based on age. History, if you've had a prostatic stone, if you've had any history of a previously diagnosed UTI, and for chronic prostatitis, any recurrent UTIs that had seeded bacteria into the urinary tract from the infected prostate. With an acute bacterial prostatitis, as we said, associated with a UTI, and it may have an abrupt onset with abrupt type of symptoms, frequency, urgency, fever. Chronic bacterial prostatitis is a major cause of bacteriuria, and both can be caused by Klebsiella, Pseudomonas, Enterobacter, gonorrhea, Staph aureus, etc. When we talk about the non-bacterial prostatitis, the findings can be similar to those with a patient that has chronic bacterial prostatitis, but there's no evidence of bacterial infection when you do your urinalysis and urine culture. Prostodynia presents with signs and symptoms of prostatitis, but you don't have any symptoms of or evidence of inflammation. With your prostatitis that's considered bacterial, whether acute or chronic, you can have a purulent prostatic discharge. For non-bacterial prostatitis, this can be related to a dysfunction when the gentleman is trying to avoid, such as spasms at the bladder, neck, or the urethra. And then prostodynia, it can be related to sphincter problems, tension in the pelvic floor, anxiety, stress, or depression. So some of the signs and symptoms that you may see when your patient presents clinically, subjective findings is tenesmus, which is that spasmodic contraction of the anal sphincter. They may complain of pain in the rectal area, and then the persistent need to empty their bowel or bladder with a straining effort. There may be signs and symptoms of a weak urine stream, difficulty emptying the bladder, and continuous dribbling. And all of these symptoms are common of both acute bacterial prostatitis and prostodynia. When the patient comes in, you're going to be exploring more about the signs and symptoms that are related to the history, and on page 657 there is a focus of history for the symptoms of prostatitis, and I would encourage you to look at that. So for example, acute bacterial prostatitis, they have some generalized complaints: fever, chills, malaise, urinary complaints. On your physical exam, you may note that the prostate is warm. It may be boggy and very tender. Chronic bacterial prostatitis, it'll describe the symptoms and give you more information on what your prostate might feel like on physical exam. So review that chart. A rectal exam should be performed with care, because if you're over manipulating the prostate, it can result in a release of bacteria. In chronic prostatitis, the rectal exam may reveal a tender prostate, but it's usually not swollen or boggy. Diagnostic test that you may consider would be a CBC to see if there is leukocytosis and a shift to the left for the bacterial component. Urinalysis. You may consider a fractional urinalysis if bacteria was found on the UA. You also may consider a CT or transrectal ultrasound if a malignancy or an abscess is considered, and then there may be the need to do a needle biopsy of the mass or aspiration of an abscess for a culture if concerns, and that would be done by a urologist. Your differential is wide, but it could include cystitis, urethritis, pyelonephritis, epididymitis, prostatic abscess, malignancy, a stone, foreign body, or acute urinary retention. Also, acute prostatitis can mimic signs and symptoms of diverticulitis, but that's where your history and lab tests usually will differentiate between the two conditions. So you've determined that your patient has bacterial prostatitis, and now it's time to decide, okay, does this condition, can it be managed outpatient, or does the patient have to be hospitalized? So if your patient presents with no fever, you are likely okay to continue with outpatient treatment, but inpatient may be necessary if the patient becomes toxic, if they're immunocompromised, if they've had a proven or suspected abscess, or if they have signs of urosepsis. If you have a patient that looks extremely ill, you'd want to admit them, and then they can be treated in the hospital with Cipro every 12 or until they've been afebrile for 24 to 48 hours. You can also treat oral Cipro and then also Levaquin. And for prostatitis, for the oral medications, those are typically given for anywhere from 4 to 6 weeks for a total treatment time. Other medication alternatives may be your Bactrums and then your doxycycline. And on this slide, there's some dosage information regarding that. It's important, if your patient should end up in the hospital, that they receive good fluids to keep them hydrated, as they may not be able to take fluids in orally based on how they're feeling. Catheterizations are contraindicated with patients with bacterial prostatitis, as that can impact and influence the prostate. And then you could have a suprapubic catheter placed if urinary retention develops. So if your patient is found to have chronic bacterial prostatitis, one of the best treatment regimens and very affordable treatment regimens would include Bactrim, but you could also treat with erythromycin, cephalexin, and the quinolones. And these would be patients, since it's a chronic condition, that could be treated for anywhere from 6 to 12 weeks with antibiotic therapy. The next slide talks about non-bacterial prostatitis, and when you first read this, you say, okay, that's prostatitis without bacteria. And the book will tell you that the etiology of non-bacterial prostatitis is uncertain, but that patients do benefit from some antibiotic therapy with this form of prostatitis, and erythromycin, QID, Bactrim, or a combination with a fluoroquinolone is very helpful to these patients. And then also they may respond with nitrofurantoin. With non-bacterial prostatitis, there can be irritative symptoms that can be treated with NSAIDs, muscle relaxers, anticholinergics. Sitting in a hot sitz bath can be beneficial. Normal sexual activity, as it'll empty out the prostate of those fluids, and regular and mild exercise. It's important to avoid spicy foods, caffeine, and alcohol, as those can impact the symptoms in the prostate. And then if there's intractable disease, a surgical resection may be considered. For follow-up, if your patient is known to have blood in the urine or an elevated PSA, then that is a urological consult. Also, follow-up urinalysis is needed approximately 30 days after beginning treatment to make sure that there's resolution of the bacteria that is noted in the urine. Your patient should be monitored until there's no longer any signs of infection, and then suppression antibiotics have been beneficial with prophylactically if you have recurrent symptomatic affections that occur for the prostate. So you may find those nitrofurantoins used, and the medication is taken daily to help prevent further infection. Recovery with prostatitis is very good. It is known to have a 55 to 97% cure rate. And then the National Kidney and Urological Diseases Clearinghouse has information that is beneficial to pass along for patient education. So consult that source. The next thing in our book is chronic pelvic pain syndrome, CPPS, and that is found on 658, and I'm going to let you review that in the book. And we're going to move on to epididymitis. And that's an inflammation of the epididymis. Your patient may present with scrotal pain, swelling, induration of the posterior lying epididymis. There may be scrotal wall edema. It also may involve the adjacent testicle. The inflammation of the testicle is usually unilaterally painful. It's also known as epididymoarchitis. So some of the causes, if the patient's had a history of unprotected sex, a new sexual partner, history of a UTI with pain, urethral discharge, heavy lifting or straining. Gentlemen that are sexually active that are on the younger age spectrum and the older gentlemen with UTIs are most commonly known to have epididymitis. It may also occur in prepubertal boys, but that is more unlikely. In gentlemen younger than 35, it is usually caused by an STD such as chlamydia or gonorrhea. Greater than 35, caused by bacteria, usually E. coli, and sometimes Pseudomonas or Staph aureus. And usually the cause is a urinary reflux that backs up into the area that causes the infection. As we talked about risk factors, UTI, particularly prostatitis, the transmission of pathogens via indwelling catheters or surgical procedures, or urethral stricture or STDs. Regarding the pathophysiology, knowing that a patient has immunosuppression, trauma, or reflux of urine from the urethra through the vas deferens can cause a chemical inflammation and edema within the epididymis, which could lead to some form of obstruction in the ductus. Some predisposing factors in healthy individuals could include heavy lifting, prolonged bike or motorcycle riding, sexual activity. Subjectively, your patient may complain of scrotal pain that irradiates along the spermatic cord or up into the flank. Pain at the tip of the penis. There may be some urethral discharge or other symptoms of UTI. Elevation of the testes and the epididymis will relieve some of the discomfort, and fever and chills can occur with severe infection or an abscess. Objectively, you may note swelling of the scrotum. The testes may be indistinguishable from the epididymis as it is so inflamed. The scrotal wall may be thick and indurated. There may be nodularity noted, pyorrhea, and a rectal exam may reveal a tender prostate. Diagnostic tests that you may consider would be a urinalysis, which might show pyorrhea or leukocytosis. If there's urethral discharge, it may show a gram-negative intracellular diplopia, which could be a form of diagnostic for gonorrhea. The culture may also be consistent with chlamydia. Your CBC may show increased WBCs with the left shift indicating infection, and an ultrasound of the scrotum can be used to diagnose the epididymitis. Differential diagnoses could include epididymal congestion after a vasectomy, testicular torsion, torsion of the appendix testes, mumps, orchitis, testicular tumor, or testicular trauma. It can also include an epididymal cyst, spermatocele, hydrocele, and varicele. Okay, sorry about that. I obviously didn't click off when I thought something had come in. So let's talk about testicular torsion, which we know is the twisting and rotation of the testicle that results in ischemia to the area. It's considered a urological emergency, and it can twist anywhere from 90 to 360 degrees around the spermatic cord. Regarding the causes, it can occur at any age from newborn up to 80 years old. The peak ages are between 10 and 20, with 2/3 of the cases occur between 10 and 20-year-olds, with the peak age of 14. It rarely occurs in older gentlemen. The torsion of the appendix testes is more common in children age 7 to 14, and some contributing factors is males that have had periodic testicular pain, and then also if there's contraction of the cremaster muscle, which often occurs during sleep in approximately 50% of patients. Other contributing factors are if there's paraplegia due to the constant pressure while sitting, alterations in the testosterone level, and cremasteric contractions during nocturnal sexual response cycles, and then if there's any congenital abnormalities. Just a few things on the patho for testicular torsion. Arterial blood flow can be compromised, and this can result in ischemia to the testes. And if this is not treated, it can become an emergency situation. And then cellular damage can occur in as little as 6 to 12 hours, and this can be irreversible. So subjectively, your patient is going to complain of acute onset of pain accompanied by swelling. They may have pain for several days before seeking attention. Objectively, there may be the absence of the cremasteric reflux. The testicle may be higher in the scrotum. The elevation of the testes does not improve the pain, and there may be a small lump that is palpable on the testes, and it could be considered the blue dot sign. So diagnostically, how are we going to figure this out? Testicular torsion is primarily determined by the history and the presenting symptoms. You also can do an ultrasound and radionuclide scanning. Some of your differential diagnoses are listed on this screen. And then some findings that are associated with testicular torsion may be a thrombus, tissue edema, necrosis, or arterial thrombosis. Management of it is the compression of the vessel we know leads to ischemic necrosis. So failure to recognize the torsion and intervene will result in the loss of the testicle in 80% of the cases. And then you can have subsequent atrophy of the testes in 10% or more of these cases. So to prevent the loss of the testicle and this atrophy, these patients require an immediate referral to the ER, and in the ER they may do a manual reduction, which will help with the relief of the pain, resolution of the deformity, and restoration of the arterial blood flow. After that, there may be surgical procedures to explore why the torsion happened and to prevent it from happening again. Conservative treatment may be started, but it's going to be slower and pain may be persistent, so it's important to treat with rest, ice, and NSAIDs. Follow-up is important, and the whole goal is to save the testicle. So the average salvage rate is anywhere from 85 to 90% if torsion has been ongoing for less than 6 hours, and salvage of the testes is less than 10% if the duration of the torsion is greater than 24 hours. With these patients, it's important that they're aware that if they have further testicular pain, that it's important to report that as soon as possible to prevent any damage that may occur in the future. Okay, let's talk next about hydroceles, and we're going to try to get through this fairly quickly. A collection of peritoneal fluid in the scrotum around the testes. Causes could include nonspecific epididymitis, tuberculous epididymitis, trauma to the testes, tumor to the testes, or a series of complications due to radiation therapy. Other causes could be exstrophy of the bladder. It would increase the risk for hydrocele, and that is where the bladder protrudes through a defect in the abdominal wall. Patients that have Ehlers-Danlos syndrome are known to have a higher incidence of hydroceles, and then patients that have a ventricular peritoneal shunt for dialysis are known to have this as well. So hydroceles in infants result from the process vaginalis that fails to close during utero development, allowing for fluid to flow into this area. A hydrocele of the spermatic cord happens when this area closes, but the mid portion surrounding the cord stays open and it can fill with fluid. Subjectively, your patient may notice that there's swelling in the scrotum or the inguinal canal. These conditions are usually painless, although the patient reports a heaviness in the scrotal sac, and if pain persists, it usually radiates to the back. Objectively, one thing that you can do is to transilluminate the scrotum with a pen light in a darkened room, and the trapped fluid may appear more light pink or yellow. So the testes themselves do not transilluminate, or if there's a collection of blood, but the fluid does, so that's one way of assessing it. And the swelling may be noted in the groin or in the upper scrotum. When you're evaluating the condition, you're going to want to know if there's any serious events that led up to the hydrocele, any trauma. You may order an inguinoscrotal ultrasound, testicular nuclear scan, and abdominal x-ray. Your differential diagnosis could include indirect inguinal hernias, orchitis, epididymitis, traumatic injury to the testes, torsion, or torsion of the appendix of the testes. Exploratory surgery may be indicated for definitive diagnosis and also to evaluate if any mass was found in the testicular or scrotal area to rule out cancer. There's no treatment for a hydrocele if there are no complications or the clinician doesn't feel like there's a significant underlying cause such as a tumor. If there is further issues and needs to be evaluated, then that would be a referral to a urologist. If the hydrocele is painful, large, uncomfortable, there are some surgical options. The Jabaloy-Winkelmann surgical procedure, the Lloyd procedure, sclerotherapy, or endoscopic procedures. With these individuals, it's important that you do periodic follow-up at about 3-month intervals. Postoperatively, the patient will be monitored in 2 to 3 week intervals, typically by the urologist, and then followed by 2 to 3 month intervals until there's resolution. Next, let's talk about variceles, and they're an abnormal degree of dilation in the paniform plexus above the testes, which usually results in engorgement and pain of the testes. The overall incidence rate is 8 to 20%. There's no ethnic predisposition, and what it is a weakening of the spermatic vein, and then the pressure results in variceles in the area. Subjectively, these patients can complain of pain, engorgement of the testes, and then a sensation of feeling like a bag of worms in the scrotal sac. Like any varicosity, when the patient is in an upright position, there's tortuous veins located in the posterior and above the testes can be visualized. They can be engorged veins that can extend up into the inguinal canal. The dilation of these vessels can be more pronounced by the Valsalva maneuver. And then you can also note atrophy in the testes if there's been impaired circulation of blood flow. So on this slide we talk about grading the varicose. A grade 1 is palpable when the patient performs a Valsalva maneuver. Grade 2 is palpable when the patient is standing, and grade 3 is assessed with light palpation and visual inspection. Some diagnostic tests you're going to want to assess for sperm count, fertility. You might order a scrotal ultrasound, venography, or thermography. Some of your differential diagnoses might include a hydrocele, a spermatocele, testicular tumor, epididymal cyst, or a renal tumor. Management of the varicose is going to be to a surgeon so that they can ligate the spermatic vein and take away that weakened wall. Embolization of the coils. Conservative treatment would be including NSAIDs and scrotal support. And even though treatment measures are in place, these have not been consistently shown to improve the sperm count or improve fertility. And as we just talked about, complications could include infertility, testicular atrophy, and then a urological consult for any patient with a recent onset of a varicose, infertility, pain, or testicular atrophy. Patient education is explanation of the disease process, signs and symptoms, and what to report if there's issues. And then most importantly, the encouragement of scrotal support to help with these various varicoles. We are not going to talk about prostate cancer, but I encourage you to look at it in the book on page 664 through 668. We have testicular cancer and STIs to go through, so we're going to try to tag those on at the end of this and get through those quickly. So testicular cancer can arise from any testicular or adnexal component. They can be from the germ cell, and seminiferous tubules are the most common types of testicular carcinomas. Germ cells make up 90 to 95%, and in adults and in boys they can represent anywhere from 60 to 75% of the cancers. Testicular cancers represent 1 to 2% of all cancers in males, and the peak onset of age is 20 to 40 years old. Some risk factors include higher social status, being unmarried, and living in a rural area. Subjectively, your patient may present with a hardened lump or nodule in the testy. While performing a testicular self-exam, there may be swelling, there may be heaviness in the scrotum, a previously small testicle may be enlarged now, but generally the cancer presents as a painless enlargement of the testicle. Objectively, you may note a firm, non-tender mass, which is different from the spermatic cord structures. Your patient may have gynecomastia in about 5% of the patients, and hydroceles may be secondary to testicular cancer. 10% of your patients will be asymptomatic, but also 10% will present with metastasis, respiratory symptoms, low back pain, and then lower extremity swelling from vena cava obstruction. Diagnostically, some tests that you could perform is a human chorionic gonadotrophin, an HCG, an alpha-fetoprotein, and lactate dehydrogenase. You could do a scrotal ultrasound. An orchiectomy could be done for staging, chest x-ray for metastasis, and a PET scan to identify further disease. Your differential diagnosis is epididymitis, hernia, hydroceles, spermatoceles, varicose. So to definitively diagnose this, they're going to need a scrotal exploration and biopsy, or to do a radical orchiectomy. It's important for your patient to know that the radical orchiectomy will remove the testes completely, and then treatment leaves the patient at a high possibility of being infertile. So sperm banking should be considered prior to, if that is something that the patient desires. Staging. information is on page 670 and 671 in the book. And then the 5-year survival rate for those with stage 1 non-seminous is anywhere from 96 to 100% after treatment. So early detection is very important in these gentlemen, and then getting them treated. For testicular education, it's important to let your patient know that losing the testy will not affect their ability to have a prosthetic in place to stimulate the weight and feel of the testy, and all the surgeries remove lymph nodes. They do not compromise the gentleman's ability to have an erection or reach orgasm, but it can interfere with ejaculation. We talked about a few of these for patient education. The options of sperm banking, open discussions and reassurances, and then also the importance of monthly testicular self-exams. So the patient is able to further assess the other testicle. Okay, very briefly, in about 5 slides, let's talk about STDs, and the guidelines for all known STDs are available at the cdc.gov. In your book on page 673 through, I'm not for sure, through 663, 673 through 677, there is a section on sexually transmitted infections, talking about the agent, how they present, diagnostic reasoning for any testing that you will do, and treatment that is based by the CDC. But let's talk a moment about causes. So those that are at increased risk for STDs are based on marital status, race, background, level of education, number of sexual partners, and lack of availability of health care. We know that these conditions are spread by an intimate person-to-person sexual contact, especially through mucous membranes of infected bodily fluids. With concerns for an STD, you want to screen for syphilis, screen for HIV. Any patient that is treated for gonorrhea also needs to be treated for chlamydia, and then all sexual partners must be notified of the potential for infection with them as well. With your young adults in early teenage years, it's important to talk with them and ask and be advised at every visit about sexual practices, use of condoms, and the benefits of abstinence. And then patients with previous STD infections or those who are practicing high risk behaviors should be screened on a regular basis. Also educate your patient that if there are concerns, to seek treatment as soon as symptoms may occur, and educate your patient that active STD infections increase the chance of becoming infected with HIV as well. So that was really quick on the STDs. Be sure and look in your book for more detailed information, and that is the end of Chapter 13, Men's Health. Thank you.